I'm here today with Dr. Lee to talk about the history of present illness in neuro-ophthalmology. Oftentimes in medical school, we are given a mnemonic for how to create a history of present illness. That mnemonic is old carts. It starts with onset, location, duration, characteristics, associated symptoms, radiation, timing, severity of symptoms from 1 to 10, and then aggravating and relieving symptoms. Dr. Lee, what are your thoughts on this method for creating a history of present illness?
So like our other video on chief complaint, I think this type of structure is very useful for medical students. I actually have nothing against what you just said. I think what I would say in terms of making it more neuro-ophthalmologic specific is we want to have all of the features that you just mentioned. However, we want to start the illness when they were last well. So instead of it being the present illness, we prefer that we hear about every doctor and every visit from the time the patient was last well to the current day. Because if you start with the vision loss or the double vision, as is very common as in an HPI for ophthalmology, you would start with everything you just said. When did the vision loss start? What were the precipitating and palliating features of the vision loss? When in reality, there was something before the vision loss that actually was important in establishing the differential diagnosis. So much like the chief complaint, we'll do the same story. And if you haven't seen the chief complaint video, I urge you to look at that because that's really important to what I'm going to say now. So when we make a focus stem with a chief complaint, like a 20-year-old white female presents with acute unilateral loss of vision, pain with eye movement, and RAPD and a normal fundus, we know that we're going towards optic neuritis. So in your HPI framework, we would say all of that, and we'd be starting the HPI at the time of the vision loss. However, if we modify that stem by including when they actually were last well, a 20-year-old white female presented 4 weeks prior with new onset hiccups, nausea and vomiting, and had symptomatic sleep attacks consistent with narcolepsy, who has vision loss, pain with eye movement, and RAPD and a normal fundus. That stem actually starts with the GI symptoms, then the hiccups, then the narcolepsy, and so now the differential move from optic neuritis towards something way more dangerous, neuromyelitis optica. So when we have NMO patients, they often have disease before the vision loss. Now myelitis is easy. These other strange symptoms are area postrema involvement and other aquaporin 4-rich areas that have caused non-demyelinating like symptoms. It doesn't even sound like demyelinating disease. And so in the HPI for optic neuritis, we would not start with the vision loss. We'd start with the systemic symptoms that preceded the vision loss. Likewise, for a chief complaint of giant cell enteritis, an 80-year-old white female presents with acute unilateral loss of vision to no light perception. She has a relative afferent pupillary defect and a normal fundus. Well, that's retrobulbar optic neuropathy, but not from optic neuritis, from ischemic optic neuropathy, called posterior ischemic optic neuropathy because we don't see the disc edema. But really, the symptoms didn't start with the vision loss in this 80-year-old patient. They had 3 months ago jaw pain when they chew their food, scalp tenderness, headache, and polymyalgia rheumatica, pain in the proximal hip and shoulder girdles. So when we start the HPI with the vision loss, you miss the opportunity to actually get the systemic symptoms that preceded the vision loss. And so for me, the thing that I most have a problem with in terms of the way the HPI is being taught to medical students is they tell you to start with everything you just said, onset, quality, duration of the vision loss. And I think we should start the history with the present illness with the past, because the past is prologue. And what that means is we should really start when they were last well and then get to the vision loss. And that is what I do in Neuro-Op for my HPI.